be joining us very soon, and Dr. Appaji Krishnan, who's the current secretary of the ASSI, and of course the president, Dr. S.K. Srivastava, and the president-elect, Dr. Ajoy Shetty. I'm Abhay, and I'm going to welcome you to this webinar on a topic that's of high interest and high fidelity, if you may, because spinal infections is something that has been changing its face, on year, and as people who working in the industry, we find that it's getting harder and harder to treat. So we've got a whole plethora of some of the leading experts in spinal surgery. And to begin with, I'm going to introduce my very dear friend, who's one of the first names in spine surgery in Western India, Dr. Bharat Dave from Stavya Hospital. And Bharat Bhai is going to talk to us about a very rare but very poignant and pertinent infection in the spine. I'm going to not disclose the topic and let Dr. Bharat take over. We'll take questions at the end of every lecture and finish that topic because the topics are very, very varied. So Bharat Bhai, it's all yours.
Yeah. Thank you, Dr. Abhay, for the introduction. Thank you, ASSI, for giving me the opportunity. I'll straight away start my presentation. And so as we know that spinal infection is something which is quite, one of the rare but uncommon situation which we all face. And, it sometimes takes our breath away as well. So I'm going to start with the case which is quite uncommon. This 33-year female came to our clinic in 2017 with back pain and some imbalance while walking, but she had normal neurology with SLR restrictions. She had these X-rays which were taken in 2017, which looks, the destruction of the vertebral body at the DL junction and with some crooked posture. That's the MRI which looks like. As you can see, that was in 11th April 2017. There is significant epidural component which is extending up to C7. And she had normal neurology, but then considering to her imbalance, so we had the diagnosis of D12L1 spondylodiscitis with anterior epidural collection, which goes up to C7. And with that, we thought that it could be tuberculosis with the epidural abscess, or it could be some kind of weird abnormal situation where the infection has spread right up to there without major significant illness. You will have it in the pyogenic spondylodiscitis. So sometimes brucella also presents fungal infection, obviously, and some parasitic infection, which we thought, and could be hydatid and could be subarachnoid cyst with the mixed combined picture as well. That's what something which came to our mind. So with that, we thought of operating her, and that is what we had done. So we did put the feeding tube, and this is something which we do quite frequently when we have such anterior epidural abscess. We have gone up to even C2 as well in one of the tuberculosis case as well. So we had put the feeding tube from DL junction. We corrected the deformity. We put the bicortical screws because we didn't want to extend our fusion level. And there were cysts which were found, and we were considering the diagnosis of hydatid cyst. And we usually, whenever such cases are there, we usually give the hypertonic saline. Even in the malignant cases also, occasionally we give the hypertonic saline wash as well. And this turned out to be hydatid cyst. So she was treated with that. She came back in June, all well, complained nothing. She was all going good. And we usually go for the routine ID reference that was done. And she comes back in December 2017 with neck pain for 1 week. And she had upper motor neuron lesion. The plantars were upgoing, and she had disturbed sleep as well with the neurological deficit. And you can see that the lesion had extended up to now C5, which was anterior, and extending below up to D4. So perhaps we may have left some, the cystic lesion there. So now the question was how to address this. As you can see, there was recurrence with myelopathy, with neurological deficit, with the lesion extending from C5 to L3, with the anterior compression. So the question comes, what next? And that was something which had the neurological deficit, which was nearly Frankel B. She was on the stretcher. So the question comes again, these are the MRI. MR myelo here plays the major role because that's the diagnostic as well. It looks like a grape clumps. That's what you can say, that this is the diagnostic feature of the hydatid cyst as well. So we thought how to approach this. So we decided to do the C6 corpectomy, which was a virgin area for us, but then we managed to put the drain tube, the feeding tube of size 8 from top to bottom, right up to L4, and we were able to give wash and then aspirate the whole pus abscess as well. And this is the post-operative X-ray with the corpectomy, immediate post-op. And this is the post-operative MRI as well, which was done on the February, which shows the good clearance of the cyst. Now, she was coming to regular follow-up. 2018 she came, 2019 she came, she was all okay. She continued to have the treatment of ID, and albendazole was given on the higher dose as well. She continued with the treatment. She was okay till 2025. And again, she came with the recurrence of the lesion, and this time she had stopped treatment on her own because she was doing good. And now question comes, what next? Because then she came again in with the quadriparesis, myelopathy, spastic paraparesis. She denied admission at that time, but then she came again in the January. This is what it looked like. And January 25, that's what it looked like. Then she surrendered in the February because she had the surgery done. We went up to the level up to D9, removed all the pus which was going up to there. Again, the medicines were given, the hypertonic saline wash was given as well. But this time we could not get her back from her neurological deficit, and she remained paraplegic. And she had Frankel B. Fortunately, she had some sensory preserve, hypoesthesia, and this is the post-operative MRI which was done after the surgery, which you can see that the good drain, you can see the even drain insertion as well. We usually keep the drain in the epidural space. The feeding tube was kept in there as well. And patient was admitted in the March 2025. She had some flicker of the toes, cordyceps came back. And before present in this case, I inquired and she is now able to walk with the walker and with the support. So that's the latest, the MRI X-ray done in June 2025. Since then, she's from Jamnagar, so away from our place. So when I looked at the literature, so it's called cluster of grapes appearance. Multiple thin-walled non-enhancing cyst should ring the bell that this is hydatid cyst. There may be cord compression. These two articles, spinal cystic echinococosis, and this is another review article. These two articles, they are must to read when you think of hydatid cyst, how to manage. And it says that there is 45% of the skeletal involvement is in the spine. So that is something which we all really, need to know as well, because then this is not that rare as far as the spinal infection and the hydatid cyst is concerned. So albendazole higher dose need to be given. Well, sometimes they say that it's lifelong, as our patient stopped because she had a very good relief from 18 to 25. And then after that, she was defaulted and then she ended up with the recurrence of the lesion. So we kept on talking to her, we kept on explaining her that, these are the red flags, you need to come back. But then she ended up with the paraplegia when she presented. So monitoring is very important. And protect the field. So during surgery, what one should be doing, cover the surrounding tissues and give the hypertonic wash. This is very important because then it will kill the cyst or the spillage. Anaphylaxis should be considered. So usually we kept on observing on table the pulse, blood pressure and given steroid as well. And after clearance, again the irrigation with the hypertonic saline should be given. So the key message is recurrence can occur later. No residual cyst is seen. Still, it can lead to recurrence. And that is what probably in our case as well. Recurrence after multiple operation is characteristic of vertebral disease, and that is not necessarily evidence of technical failure alone. So recurrence surveillance is very important. That's the key message to be given, and surveillance is to be lifelong for the hydatid cyst. Thank you. I'm open to questions.
So that was a fantastic exposition of a rare spinal infection. But I think most of us have seen one in our careers. I think most of the faculty here would have seen at least one hydrated cyst in the spine. Bharat bhai, if I can shoot the first question, is there some diagnostic, like a easy red flag on MRI scan that can pick up a hydrated from, a hematoma or a tuberculosis or a pyogenic infection?
Yeah, so whatever is seen there, the cyst, it is the CSF intensity. So it is bright and it is like multiple loculated as well. So it is a grape cluster. That's what is the identical. That's what should be the diagnostic, and that's what should ring the bell. Oh, I'm looking at something which is like hydrated cyst. And obviously, one would ask the patient as well whether they have the anipal exposure. And she is the one who lives in the farm.
Also, is there any blood work or systemic test that can, because biopsy looks like a
Yeah,
far
yeah,
impossible, right, to do
yeah.
biopsy because it can actually
So
lead to a problem.
yeah, as such, there were no red flags for the pyogenic infection. All her blood workup was normal when she presented on day one. So, that also should ring the bell as well, that was something which was, we are dealing with something different pathology.
And as far as treatment goes, is there any algorithm that suggests that you should start albendazole before you do any surgery, or should
Yeah,
you go ahead and do everything
yeah.
together?
The literature says albendazole should be started before surgery, at least a week before surgery. That's what the literature, these two articles, they mentioned that it should be started before surgery. But then, patient usually they are defaulted. Once they consider that they are, they have relief, they have good relief.
And
What's the
albendazole should be
dosage
continued
like?
lifelong. Sorry,
Sorry.
lifelong albendazole.
Yeah, well, they say that it should be given for 6 months, but our ID says that it should be taken for lifelong.
All right. Yeah, Suresh, sir.
What's the dosage? What's the dosage?
The dosage is 10 to
Dosage
15 milligram per kilogram. It's not the it's a higher dose.
daily dosage
Yeah, it's a higher dose. It's a 10 to 15 milligram per kilogram.
per day, every day.
Every day, yeah, every day. Single dose.
Because the only hydrated that I've treated, I did surgery 4 times, and then she got on a lifelong albendazole, and since then she's never come back. So
Yeah.
I don't know
Hopefully,
whether how
that's
it
good,
would.
yeah.
Yeah. Any other questions from the audience or from the faculty? Samir, Piyush, Nupam?
Any serological test?
A
Any
steroid
serological
normally is
test
not
available for this?
required unless you are thinking of anaphylaxis.
Serological test.
So the
Serological
steroid,
test.
we had the steroid ready
No,
on
no, not
table, but
steroid.
sorry,
Serological test, any blood test?
Serological test.
serological test, not of any help. No,
So when the patient is on albendazole lifelong, is there anything specifically that you must monitor?
not
Anything,
really, not really,
any
not
side
really.
effects that you should be mindful?
No,
Currently
not
super
really.
safe, sir.
Okay. Okay.
Fantastic. So it's a very rare situation, but remember that since all of us have seen it once in our life, you're going to have to see it once in your life.
Yeah, that's
So you
right.
better know everything about it. I think the articles that Bharat Bhai has shared with us, I think will go a long way. Thank you, Bharat Bhai. I understand that you need to leave for another part of your academic evening. So thank you for being with us and sharing that wonderful presentation. We'll let you go away and
Thank
stay
you.
with the SSI for the next session. Thank you again.
Thank you. Thank
We'll
you.
quickly move to fungal infection of the spine, which is the next natural follow-up. Again, a rare condition, but in the era of progressive, immune deficiency amongst us as patients, I think fungal infection is only here to stay. So we have Dr. Samir Ruparel, a busy, young, dynamic practitioner from Bombay, and he's going to talk to us about fungal infection of the spine. Samir, it's all yours.
Very good evening, sir. I'll just share my screen. I'm just trying to do that. Just give me a minute. So is this visible?
Yeah, it is, but it's in patches.
Now?
Yeah, now you're fine. Go ahead.
Very good evening, sir. Thank you for giving me this opportunity to present the case of fungal infection. As Bharat that the patient had undergone multiple surgeries. My is probably a relatively rare but a simple case. So this was an 83-year-old lady, which I had the pleasure to see in the ICU directly. And she had been a known case of diabetes, blood pressure, and chronic kidney disease since a long time. Her main complaints were back pain related to both lower limbs since almost 2 to 3 months, and it was progressive in nature. And she had paresthesias in both lower limbs. Since last 1 week, she had developed both lower limb weakness, and it was below knee weakness, right, which was more than left. And this was the X-ray, which particularly showed that there was involvement of the L4-5 disc space with significant erosions of the upper end plate of L5 as well. And this was the MRI of the patient. As we can see, there is a significant collection which is there. There is an epidural collection as well. And 4 and 5 vertebral bodies have been involved significantly with nothing significant on the whole spine screening. To add to this, the patient already had undergone a CT guided biopsy, which was done 1 month back elsewhere, and it was inconclusive. And the patient was empirically started with AKT. Any thoughts as to what, the case is open to the faculty and for discussion as to what would be the cause of this? I mean, actually, it has been already the cat is out of the box that probably it could be a fungal infection. But anything on the MRI that point it could be a fungal infection, or what would have gone wrong that we were not able to on the biopsy to in the first stage? Any
It's a
thoughts, Abhay?
good question. It looks like a chronic granulomatous infection because not a lot of soft tissue and a lot of bony destruction. So it's tiptoeing on the TB kind of a process. At the same time, you'll see there's a lot of osteitis around the spondylodiscitis, which is not very characteristic of TB. So of course, if it was fungal, I would have expected multiple bones being affected, which I don't see. And were there any patient risk factors for a fungal infection?
The patient had a chronic kidney disease and
Diabetes,
particularly old age. So probably those were the only two risk factors based on history that could, possibly be fungal.
Right. So chronic renal disease, actually in my career has pointed more to pyogenic than to fungal. But of course, radiologically, this doesn't look like pyogenic. Suresh, any inputs?
Yeah, she's not diabetic, isn't it? That is one
Diabetic as well.
association. Then the TB-like picture may be fungal infection. They usually present with TB-like picture, and a lot of abscess in case of tuberculosis or calcification in the abscess is more in favor of tuberculosis. So we can give a DD for this.
Right. So, when I went in for since the patient had developed a neurological deficit and the biopsy was inconclusive, if we didn't know that this was probably a fungal infection, what would be the further plan? We should repeat the biopsy, or in view of neurological weakness, we should directly consider the surgery in this case.
Again, to be fair, I think many of us would have gone ahead with surgery because it would be an open biopsy and a reconstruction, decompression, fixation. Because the only thing that would change your plan of management would be a malignancy with metastasis or something. So no matter what infection it was, I may have actually jumped the gun and gone and done a surgery.
So that is what I did. I went ahead and I counseled the patient in view of neurological weakness that we should do the surgery. But with regards to the surgical plan, considering that we don't know what the pathogen is, we don't know whether it is fungal or not. What would be the levels of fixation? Whether we would use metallic implants in this? What kind of use, and the levels of decompression for the panel?
Yes,
Dr.
Suresh,
Patel?
Piyush, anyone wants to bite that bait? Jaspal, Mohit, Nrupam.
We don't know what the pathogen is.
If you suspect, if you suspect fungal infection, instrumentation may be a wrong choice mostly. Otherwise, if it is tuberculosis or any other infection, we can very well go ahead with the titanium instrumentation.
So we don't know. We don't know what the pathogen is. We are just going in because the patient has developed a
Then,
neurological deficit.
then,
Fixation would be short versus
then
long.
better to confirm. Then better to confirm the diagnosis by with adequate sample, and then go ahead and the second time for instrumentation.
Okay. Dr. Abhay sir, would you agree with the plan? I mean, within
Yeah,
a
so
3
I
to
would
5.
probably still have succumbed to going in, directly and done bone graft TLIF. I am happy to put implants in the posterior, posteriorly, but interbody, I would have put a bone graft or an allograft and
Would
skip
you
the
go long segment fixation? The
most
level?
likely not in this case. Okay, it's an older person. I mean, I'm conflicted whether I would do a segmental or a double segment fixation, but I think I would do a segmental fixation. Just a 4 and 5 interbody fusion. Yeah.
And sir, skepticism to put the implant anteriorly into the disc space.
Yeah, I would have put a bone graft rather than an implant. Like I wouldn't put a cage there. I would put an allograft, though literature doesn't necessarily tell me one way or the other. I'd like to hear from you what fungal, infection tells us. But otherwise, I would have just gone in and put in an allograft.
Dr. Pillai, what are your thoughts in terms of putting cage anteriorly in infections?
If at all, if I suspected fungal infection, I would do, I can put a bone graft interbody fusion, but I will stay away from putting the instruments because many times this fungal infection, you may have to, you may end up removing the implants later on. So if I am not sure of the diagnosis and my bet is more in favor of fungal infection, then I will do a laminotomy then or phlebotomy and take adequate material for culture, biopsy, all those things. And then only and after the diagnosis only, I will go for the interbody fusion. And when I go for the interbody fusion, if it's not fungal, with one antifungals, maybe one level above and four, 3 and S1. I won't put screws in the 4 and 5 because the upper part is eroded, the lower part of L4 is eroded. So my choice would be L3 and S1 fixation when if it is fungal, then after 1 or 2 weeks of antibiotics.
Okay. So this is what I did. I went for the surgery in this patient, and this is what. So I went for the fixation from L3 to S1. I decompressed the level. I did a transfer lumbar interbody fusion, and I didn't know what the pathogen was, but I was suspecting that it would be tuberculosis. But still, I was skeptical in putting the cage anteriorly since it was opening up quite a lot. Um, and I was a little skeptical that probably the cage might not get a good fit. So intraoperatively, I basically took out the spinous process, which looked good. It was not involved in the MRI as well. I put the whole spinous process along with calcium phosphate crystals and filled it up with the whole disc space basically. And this is the post-op X-ray. The biopsy then showed after a week that it is a fungal. And then I referred it to the ID specialist. It was the organism was Candida tropicalis, and it was sensitive to micafungin and fluconazole. So the patient was started with micafungin and then fluconazole for 600 milligram for almost 6 weeks. So the duration was injectable for 2 weeks and then tablets for 4 weeks. This is what was done. This is the 3 months post-op X-ray of the patient, post-op as well as the MRI. And this is the MRI, the X-ray of the patient at 1 year, which shows collapse of the disc space because I didn't put a cortica, a proper cage. But the patient is doing well. Her neurology recovered. And this is the MRI, which shows good decompression and the fungal elements were, completely resolved as per the MRI report. So that is what. Fortunately, the patient is good, but yes, it was my encounter with a fungal infection for the first time, which I didn't suspect. And it was difficult to make decisions intraoperatively since I took the patient up in view of neurological weakness, quite in an emergency kind of a situation. So,
Great, Samir. What was your take-home message then here? Like, how would you
so my
change
take-home message
in your
I
practice?
feel is that probably the first biopsy also failed is because probably, very few people, I don't know, but the fungal smear and culture is something that should be added to our armamentarium of investigations whenever a biopsy is done. We usually take into consideration tuberculosis, aerobic, anaerobic cultures, but a fungal smear and culture should also be included routinely. And probably that's the reason that first biopsy didn't show anything. And if it had been shown something, then all these things would have been avoided. This is
And do
what
you
I
have any data on
How long did
using
you?
antibody implants in presence of active fungal infection?
Well, the literature is quite sparse in terms of fungal infections also. I didn't find the case, particularly with the use of metallic implants in fungal infections, as per the review. But yes, there are very few case reports which document fungal infections in the spine.
Sure. Suresh?
I had a few cases of fungal infection, but which were done elsewhere. They came with the fungal infection. All of them, I had to remove the implants because they were the loose. The implants were loose, so I had to remove the implants. That's why I was skeptical about putting the implants. So Samir, how long did you treat him with the antifungals?
6 weeks, 6 weeks. So this was under these are under the ID specialist. So micafungin was given 1 milligram for 14 days, and then fluconazole was given milligram for 4 weeks. So total 6 weeks.
So, sorry, I had a question, sir. So, how did you decide to stop the antifungals? Do we follow the same algorithm as for other infections, or we just see clinically bloods? Is it the same thing?
So basically, this is based on the culture sensitivity and the ID specialist's opinion. We had involved the ID specialist as well. So usually the in antifungals are usually given for 6 weeks to 3 months. In this patient, the uh, clinically she was getting better and she was sensitive to the drugs as well. So the ID specialist took the plan of giving it for 6 weeks basically, 2 weeks or IV and 4 weeks only.
And how do you monitor these patients? Any blood parameters that you check after a
CRP,
certain time of stopping the
CBC is our
antifungals?
CRP.
Okay.
So as we see,
And
he's
MRI at 3 months.
3 months, yeah.
Okay.
So it showed significant resolution at 3 months. And then I again did a repeat MRI at 1 year when she came at follow-up, and she is doing well.
And in your literature search, is there any other specific take-home message that you'd like to share with the audience?
Just with regards to the use of metallic implants, probably I think it is not yet conclusive that we can use a metallic implants in the diseased area. That is one.
Super.
So there's one more question. Actually, Dr. Tausif is asking. Do you feel screening for fungal infection should be routine practice for all biopsies, or should be done in selective cases?
Well, I practice as routinely as a routine practice. All my biopsies, I add fungal smear and culture. Dr. Abhay sir or Dr. Pillai sir would like to add something to it.
Yeah,
Yeah, I
we
mean,
also send all the samples for fungal culture as well, routinely.
yeah. So the
It
cost
just costs 1,000 rupees more.
Yeah, you're right. But sometimes every place is not even available. So I think a more watered down version would be that if there is a patient profile that demands, immune deficiency kind of a background, then definitely you want to send for fungal. And of course, if cost is not an issue and availability is all good, then you should probably send for fungal. Great, Samir. So fantastic. I think we'll wrap that up with your final comments and move on to the next
Thank
topic.
you.
Thank you, Samir, again.
Thank you.
Suresh Pillai from Kerala is going to be our
Yeah.
next speaker, who's a very experienced and obviously one of the rock stars of ASSI, and he's going to talk to us about meningitis. So Suresh, it's all yours.
Yeah. Thank you, Abhay, for the words. Shall I share the screen? Is my visible? Hello, am I audible? Abhay,
We can hear you, but we can't see your presentation.
not. Now, is it
No, Suresh. Only it says
is it
Suresh.
visible now?
Started, no, it started sharing screen. Yeah, now it's visible. Thank you.
Oh, okay, okay. Thank you. So this is I'm presenting a highly dramatic uh, insect case of post-operative spinal infection that ascends to cause septic cerebral emboli and how a classical clinical anchoring bias almost cost the patient her life. This case highlights the critical importance of looking beyond primary history, inspecting radiology personally, and deploying immediate multidisciplinary salvage protocols. We will review the timeline from initial surgical error elsewhere to our definitive surgical and targeted antimicrobial salvage and discuss the lessons every practicing spine surgeon must take home. At the onset, the patient was a 55-year-old female who underwent L3-5 posterolateral fusion for lumbar canal stenosis elsewhere. On 6th of
Your
June
slide is not
2026,
moving, Suresh. Your slide is
with
not. We are still on the title slide.
oh, I have moved it. Now,
No, only the title slide is being seen.
that could be wrong. Now,
No, you want to
is it
unshare
visible?
and share again? The title slide is visible, but we can't see your in the second slide at all.
So I'll stop share and then
Yeah,
reshare.
stop share and reshare, please. Because as you all can know, this is a very important topic, and I think again many of us as faculty have had this situation where CSF leak and post-op infection has led to meningism and meningitis, and personally I've even had a death. So it's a topic of great grave concern, and a simple lumbar decompression surgery could go south. Suresh, you want to unshare once?
Is it visible now? I think
No,
what
the
I'll do is
title
I'll
slide
just
is visible.
put my slides.
No, your title slide is visible. Yeah, now share again.
Yes, I'll do once again. Uh, so I'm sharing the screen again. Is it visible now?
Not visible.
Title also?
No, nothing.
Oh, test. And now I had some good, interesting things for you.
Yeah, it's obviously a very interesting presentation. But if you think it's taking time, we can move ahead with tuberculosis and come back to meningitis.
Let me try once again.
Yes.
So, is there any
No, this just says that you're started sharing, but nothing is being seen.
Yeah,
It
in the
says double.
meantime, I think
is
good
something wrong with the
evening,
net?
everyone.
Shailesh, welcome. We welcome our convener,
Is it
Dr.
visible?
Shailesh
Yeah.
Hadgaonkar.
Visible now?
No, not visible, Suresh.
Some lag is coming.
Your screen is loading. Yeah. So it should come. I think maybe because of the net. Now it has come.
It
No,
is.
no, it's gone.
No, it is not coming.
Screen share is loading.
So maybe we should move on with TB.
Yeah,
And
yeah.
then come back.
Jaspal, can you just share?
Yes, sir.
Well,
Because
stop sharing. Huh?
Yeah, Suresh, for now, stop sharing. We'll just come back to meningitis after
yeah,
TB.
we'll take some simple ones in the meantime.
Yeah. Is my screen visible?
Yes.
Yeah, good evening, everyone. I'm Dr. Jaspal Pardeshi, ASSI Spine Fellow at Sun City Hospital. I'd like to thanks for giving me this opportunity to present on basics of infective tuberculosis spondylolisthesis. And I'd like to thank my mentor, Dr. Shailesh Hadgaonkar and ASSI for giving me this opportunity. So we have seen all the variety of cases till now. But one case that we see daily in and out in our OPD is infective tuberculosis spondylolisthesis. Any infective discitis that we see, our first guess is it TB or is it not? So we have seen this, it holds tremendous amount of load in case workload in the country. TB is so popular in India, it consists of 27% of annual cases all over globally. So even if we know other kind of infectious spondylolisthesis, TB is something we should be knowing how to diagnose and how to treat it. So the load of TB is such great in India. According to a recent paper, uh, 48 to 52% of infectious spondylolisthesis are tubercular in nature.
Jaspal,
So
can you enlarge your screen, please?
yes, sir. Okay.
And yeah, correct. Yeah, that's correct.
So why spinal TB matters? So it is a indolent disease. It can present with chronic back pain. Symptoms can vary from days, weeks to months. It can risk neurology of patient, can cause cord compression, deformity, and even paraplegia, quadriplegia, depending on the site. It can cause progressive deformity, and it can also mimic malignant conditions. So it is very important to know how to diagnose this condition and treat wisely. Any case with any alter changes in the MRI we see in OPD, we are always at doubt: is it a tuberculosis, is it a pyogenic infection, or is it a malignancy? So we'll see how we can detect and get onto the treatment of the TB. So we should know what our organism is. So Mycobacterium tuberculosis is an aerobic acid-fast bacilli, slow growing, usually intracellular, and it reaches the spine by hematogenous spread, primarily of the chest infection, reaching to the spine. So why is spine so common? Because there are rich end arterial and venous networks at the peridiscal area where the infection can reach and then flare up. So this is the pathogenesis of the TB. Primary infection is always lung, which can sometimes heal or sometimes can be progressive. It can cause early hematogenous dissemination. The dissemination can be to skeletal TB, mostly around the around the peridiscal area or center. So this spread of infection can lead to TB from tuberculosis of the spine from the lungs. What are the clinical features we must be knowing, and what are the red flags we must be knowing? So patient complaints of back pain, he has complaints of uh, constitutional symptoms of weight loss, fever which is worsening at night. Patient can also complain of some swelling in the back, which can be a cold abscess. He might complain of difficulty in walking, loss of power, or malaise, night sweat, weight loss. So what are the red flags we must be looking after? So if there is a progressive neurological deficit, if there is gibbous or focal kyphosis, severe mechanical back pain, or persistent symptoms despite of empirical treatment. So how do we proceed with such cases when such patients present to an OPD? So we start with basic blood labs such as ESR, CRP. We start with the radiological X-ray, MRI, CT scan if necessary. So what are these labs necessary for? So basic ESR CRP helps in detecting if the condition is infective or non-infective. Mantox test can help us in identifying if the immune condition of the patient. Basic labs was blood tests, LFT, RFTs are done to know what kind of chemotherapy we can start on. So on X-ray, what are we are able to see? X-ray usually is a late. X-ray features are seen very late. Disc space collapse is seen, end plate erosion is seen, and there is deformity seen. CT scan is best for bony destruction. We can see the cortical destruction, sequester fragments, and calcification or surgical planning. MRI usually shows the soft tissue extent of the disease, that is the marrow, epidural disease, abscess, cord roots, or skip lesions. So here is the MRI. We can see there is peridiscal area involvement is there with destruction of the disc space and little local focal kyphosis can be seen. In the axial image, we can see there is psoas collection is there and soft tissue around the vertebral body is all involved. So this is all radiological imaging help us in identifying if it is an infective or differentiated from other. But in the infective also, we need to be sure if it is a tubercular or pyogenic. Radiological examination can help us, but cannot final comment or final give us a final if it is a pyogenic or tubercular. So in tubercular, we can see a indolent course of disease. There's a large, thin, smooth wall abscess there. Subligamentous spread, it is very commonly seen multi-level in tuberculosis, which is usually not seen in pyogenic. And deformity is more characteristic. And systemic toxicity not usually seen in tuberculosis, while on the other hand, in pyogenic infectious spondylolisthesis, course could be acute or subacute. The abscess could be irregular. Spread is usually very focal, limited to 1 or 2 level, not much widespread. Deformity is less likely seen, and systemic toxicity can be severe in pyogenic infection. So once we see the imaging and the clinical features, what are the differentials we need to keep in mind? Definitely, our first differential goes towards tubercular, but we need to have a backup of pyogenic infection, malignancy, or even inflammatory per se. So, how do we proceed? In any patient with presents to us with a MRI suggestive of infectious spondylolisthesis, usually we need a histopath diagnosis to start him on a AKT. So image guided biopsy, usually CT scan biopsy or Shyam guided biopsy, as preferable is done. These are the basic labs that we send: histopathology, AFB smear, mycobacterium culture, nucleic acid um, amplification test, gene expert, and drug sensitivity testing. So these are necessary to start him on the basic treatment of the anti-tubercular drugs. So we need to be very careful with the what are the biopsy samples we send. We need to be sending enough samples for histology, microbiology, or molecular testing, because any one of these tests can come out negative if we send only one of those tests, and then we might land up at wrong diagnosis, or we might land up at not diagnosing the condition. So histopathology will suggest you of something like granulomas, Langerhans cells, and chaetic necrosis. So usually microbiology, this is what we usually prefer: AFB smear, culture, gene expert. So gene expert is a rapid detection test, and we can even detect the resistance and drug sensitivity if the patient is not showing any response to the treatment. So this is the practical consideration if patient present with chronic back pain and constitutional symptoms. If the samples come out to be negative, then we have to reassess the differential. We have to review specific advocacy and consider repeat image guided or surgical biopsy. But we should be very careful in detecting is a non-tubercular or a culture negative as non-infectious spondylolisthesis. So this is the basic drug regimen that is currently followed. Usually 2 months of isoniazid rifampicin pyrazinamide ethermetol followed by isoniazid pyrazinamide ethermetol. The duration can vary from 6 months to the individualized as per as the as 3 monthly or 6 monthly MRI is repeated and the blood parameters are repeated. And once the in conclusion with the ID specialist, we feel that the infection has settled down, then we can stop according to the response of the individual. So where is the medical management and surgical management considered? Medical management in neurologically intact patient, stable spine, no deformity, no neurodeficit, no major other complaints, and patient is clinically responding to anti-tubercular therapy with um, betterment in the clinical condition, that is most important, and decrease in the abscess on the MRI and blood reports on declining as well. Whereas surgery is indicated when there is progressive neurological deficit, mechanical instability is there, severe kyphosis or cord compression is there, patient is not responding and clinical condition is not improving, and diagnostic uncertainty is there. So these are the surgical indications: neural decompression, spinal stability, deformity control, debridement when needed, and tissue diagnosis. So these are 5 takeaways that any infectious spondylolisthesis in India, we should always have our first differential diagnosis as tuberculosis. MRI will suggest us, but it's better not to start treatment on MRI, but have a tissue confirmation. Biopsy should be sent adequate sample. Molecular test testing should be used if there is inconclusive biopsy or if there is drug sensitivity, drug resistance. And if there is any of the following features of neurology, instability, deformity, compression, we should always opt for a surgical management. Thank you.
Thank you, Jaspal, for this very important presentation. As in India, they say 95 to 97% of the infections are ultimately TB, and we all should be aware of that. I just would like to ask quickly, Mohit is around, Dr. Mohit Mehta, who worked in
Yes, sir.
medical college and also in Indian Spine, and he's private practicing in Colombia, Asia, and Manipal. What is your experience and what exactly you normally see if a patient is of some kind of infection and you're
In
suspecting there is something, very classical? Mohit.
OPDs are continuous localized back pain, then extreme tenderness, deficit, and if we see deformity, then it's more often than not TB.
Okay, so these are your takeaways. Yeah. I would like to ask Piyush, what is the current guideline, Piyush? He's an infectious disease specialist in Pune and attached at Jahangir Apollo Hospital and Sancheti Hospital, and is very prominent ID specialist. Dr. Piyush Chaudhary.
Yeah, the guideline related to say diagnosis and treatment or
Yeah, just treatment. Right now, what is current standard?
yeah, so I think Dr. Jaspal has rightly highlighted that the initial phase does involve four drug AKT with isoniazid, rifampicin, pyrazinamide, and ethambutol. Whereas the continuation phase, there is one thing I would beg to differ than what he showed, that in spine, very rarely we treat for 6 months only. Very often we'll treat for 9 to 12 months, sometimes even up to 15 months. And one additional kind of thing which is now recently available with us in some centers is to be able to do drug levels in the spinal abscess or in the spinal tissue or the discal tissue which is involved in TB classically, because many of these anti-TB drugs, although they have exceedingly good penetration in the lungs, have very poor penetration inside those thick-walled abscesses or the bony parts when it comes to spine TB.
Okay,
So even yeah, so patients may be looking on correct doses, but clinically there can be paradoxical worsening, which is a very common again phenomenon in spine. That
correct.
3 4 months down the line, the MRI many times shows worsening.
Correct. So I think it's what you said is absolutely right. We also learn from you guys, and we move on in the want of time. Dr. Nene, who is known for his work in TB spine, and is working on various publications, various treatment protocols for last 25 odd years, and his wife, who is a famous ID specialist and chest physician. So let's hear from the horse's mouth. Dr. Nene is doing conservatism in TB a lot. Also, XDR, MDR, which are quite confusing facts for us. So let's hear it from Dr.
Yeah,
Abhay
I'll
Nene.
just try to cover, Shailesh, some of the issues about MDR and XDR.
Yeah,
I mean, this is a common scenario, as you can see on my screen. Someone who's had AKT on empirical basis and has actually worsened over time. And when such a thing happens in your practice, you got to think of drug resistance. And it was way back. I mean, I'm saying more than 15 years ago that we published the first international series of MDR TB spine cases, and we called it "Is it the beginning of the end?" There were only 25 cases then, and now we have hundreds of such MDR TB cases. So the old adage that tuberculosis of the spine is actually a possibacillary disease, which means that there's a low chance that this can be a drug-resistant bug, is now changed. And I think the god of spine today will say that you got to look for MDR TB in most of your spinal TB cases. So let's talk about what this drug resistance is all about. And the definition of MDR TB is resistance to INH and rifampicin. However, this could be a mono resistance, which is a resistance to any of the first line drugs, a poly resistance, which is a resistance to more than 2 of the first line drugs, and then an extensively drug resistant tuberculosis, which means that the resistance is to at least one of the 3 injectable second line drugs, because as you know, they become your best armamentarium to dealing with drug resistant tuberculosis along with quinolones. So the definition of XDR TB remains quite standardized. And as you can see, the huge controversy around this XDR-TB, and the prevalence of XDR-TB is now growing. So, which means that we've gone back, about 50 years, gone back to the era of pre-antibiotic era of tuberculosis, because suddenly now we've got a bug which has no antibiotics available to it. Unfortunately, the fact remains that the development of drug resistance is actually a man-made problem, which means you and me as physicians are actually responsible for the maximum number of MDR in the world, because of faulty dosage and poor practicing, poor guidelines and poor practice of medications in tuberculosis. Now, here's another startling fact, that in India, at least 16%, around 16% of people are natively resistant to INH, which means that they just have a genetic resistance to INH, and hence that's a huge number, isn't it? 16 out of 100 is like a huge number. And of course, almost half people who have had previous AKT are resistant to INH. The prevalence of MDR-TB in newly diagnosed spinal tuberculosis is 3.4%, but people who've had AKT in the past, that that reference moves to 25 to 35%. And especially in the pediatric population, coming from where I work at the Wadia Children's Hospital, we find that the incidence of MDR-TB is much higher in children, and there's a science behind it. Most adults who get tuberculosis, it's a reactivation of TB, of the bug that has hit you, when you were a child. That's like 3 decades ago. And hence that there was no MDR-TB then, but a child who gets tuberculosis is normally a de novo infection. And today, 1 in every 4 or 5 bugs is going to be an MDR-TB. We also recently published the cohort of MDR-TB children, and we realized that most of these had a worse outcome of surgery and of treatment. So MDR-TB is just not another form of TB. It's a different animal per se. And of course, we know that you were to suspect MDR when in a clinical scenario, you have worsening despite AKT, when you have no clinical improvement, when you have a history of irregular drug intake, when you have known contact of MDR, and we often don't ask this in the, in the family. If it's a immune compromised patient, like an alcoholic drug addict, and if there's an appearance of new lesions while on treatment, this is called secondary drug resistance, when the patient is on AKT and develops a resistance to AKT. Now, here's a detailed slide which tapers down in its in the size of the font, because there's so many new drugs available for second line treatment of tuberculosis. However, if you see the next slide, which shows the number of side effects of these drugs, it's much more, which means that the orthopedic adage that it's normally easy to stamp out bugs with these fancy named expensive second line AKT drugs, the fact is that it's not, because these are less effective against tuberculosis, though they're more expensive. They have far more side effects. They're to be given for much longer, but their utility and their robustness is much lower. And then the mortality of MDR-TB is almost close to the mortality of cancer of the breast. So it's not tuberculosis, it's a different disease. Now, what are the molecular tests that we use to diagnose MDR-TB? So you have the probe-based test, which is the Gene Expert, or the CB-NAT, which is the Desi version Gene Expert, and the line probe assay. And then you have the sequencing test. So the Gene Expert, just to give you a few few slides about that. Normally, when you do an AFB smear, you need 10,000 bacilli per ml of a sample. But for a Gene Expert to come positive, because it's a tube assay test, you require only less than 1/10 of that number, 1/100th of that number to actually get it positive. And the results are available within 2 hours, and the accuracy is almost 98%. However, there's something called cycle threshold, which means how many times you need to spin that that specimen around. And if you need to spin that specimen around for more than 22 or 28 times to be able to detect the bug, it's a low or a very low cycle threshold. And in that scenario, your result should be interpreted with caution, which means that if you have a Gene Expert that's positive with a low or very low CT or a cycle threshold, the sensitivity of the rifampicin shown could be falsely positive, remember. And that's where Gene Expert Ultra comes in. So Gene Expert Ultra is the exact same test given with a more modern kit, and It's 8 times more sensitive. The problem is that most government labs are still trying to finish their gene expert kits, and hence the gene expert ultra kits, which are supposed to have replaced the old kits, are still not available. So if in a given case, you may want to send your sample to a private lab, which still runs the gene expert ultra, because as you can see, it is 8 times more sensitive, and it can then be more accurate in determining rifampicin sensitivity in a low CT or a very low CT or a trace CT sample, which often is because tuberculosis of the spine is a possibacillary disease. So the general algorithm is that if you have a high CT, which means the cycle threshold is high, you may want to send a positive gene expert sample further for LPA to get a better assessment of the multiple drugs available for your patient. And if it's low CT or a trace CT, you want to send it for pyro sequencing or gene expert XDR. Now, here are some points which we often tend to miss, that a negative gene expert does not always rule out TB. A positive test does not always indicate a viable organism, especially someone who's had a treatment of TB done in the past. The gene expert could be falsely positive. And here's a pertinent point, that if the AFB smear is positive, but the gene expert is negative for MTB, there's a high chance that you're dealing with an atypical mycobacteria for which the treatment is completely different from tuberculosis. So in practice, if you want to apply LPA, of course, if the AFB smear is positive, you want to directly send this sample for LPA, because it gives you a much better menu card of what medicines are available for this resistant tuberculosis. If it's negative, I would suggest you do a gene expert ultra, and if that turns out positive, do LPA, and I think that's the algo that we follow. The newer tests are pyro sequencing, because the pyro sequencing of the MDR bug gives you a much better lineage of all the drugs available. And soon we are going to have the whole genome sequencing. Dr. Chaudhary might be able to tell us later whether it's available at this point, commonly. But that's going to be like literally a menu card of which medicine is available for treating your tuberculosis. As far as treatment of TB of the MDR type goes, there are standard guidelines given by the WHO, and I will not waste time on that. All I can tell you is that there at least 5 new drugs have to be given, one injectable drug, and at least the duration should be 24 months, ideally 18 months after proving culture negative. And here's the final trick question: what are the best 3 second-line drugs that you, as an orthopedic surgeon, should start if the patient fails to respond to HRZ? Any takers? It's a trick question. The answer is, please do not start any of these drugs. Send them to Dr. Chaudhary, or send them to your best colleague who is someone well versed in the treatment of MDR spine. It's not your business as an orthopedic surgeon to start treatment of the MDR. Get it right the first time. Thank you.
Thank you, Dr. Nene. I think we have, you rightly said, Dr. Piyush Chaudhary is just waiting to tell us his share of experience on investigations and various different type of infections in spine. Any questions to Dr. Nene, or we move on to the next one?
So I had one quick question.
Yes.
Sir, if you're radiologically clinically suspecting it's TB, but both you've done one biopsy, and as Jaspal said that if it's negative, you should go for a second biopsy. Both are inconclusive. Would you go in just for diagnostic purposes, or would you empirically start AKT?
Yeah, so this question gets asked quite often, and I think the answer lies in the method of the biopsy. You've got to make sure that the method of the biopsy is correct. A minimum of 3 samples should be sent, including pus sample, because pus sample traditionally is thought to be necrotic tissue, but in reality, it is a very high positivity rate. And if it's taken correctly, there's a very low chance that a treatment naive patient will have a negative biopsy. If the biopsy is indeed negative, you still want to rely on the histopathology. Like, don't forget that there's something called histology and a smear. So if everything is negative, I would say, go in for a repeat biopsy, because the difference between a CT guided or an image guided biopsy versus the open surgical biopsy is huge for the patient. So the indication for surgery should be a standalone indication. And if there's an indication for surgery, of course, you don't want to waste your time. You can just go in straight away. But I would say that that amounts to less than 10% of the patients you'll see in population. So it's a good question, Nrupam, but the answer is, I think, within your question.
Right.
Thank you.
Thanks.
Thank you, Nrupam. It's a good one. And I think we move on as the TB session is going on, it's like very, very important for us. Whether this robot and navigation is touching the TB and whether they're influencing the TB treatment. Let's hear it from people who are doing it for a long time. Dr. Vignesh from Chennai and Dr. Appaji, Dr. Sajan Hegde, they are known for their robotic work. So let's hear from Vignesh's experience. Over to you, Dr. Vignesh. Yeah. Are you sharing your screen? Yeah.
Yes, sir. Is it
Yeah.
visible, sir?
Yeah. Yeah. Yes.
One second, sir. Sorry.
It's okay.
It stopped now, sir. Sorry.
Yeah, it stopped. Yeah. Please share it again.
Yeah.
Yes.
Okay.
Go on.
So this is a case of a 14-year-old girl who was complaining of low back pain for 2 months, and the parents kind of ignored as if like she's a student and she was sitting in a place studying. That's why she might have this fatigue kind of pain. But the pain intensity was increasing on a day-to-day basis, and then she started having constitutional symptoms. And when she presented to us, her VAS score was 8 out of 10, and it was disturbing her daily activities. So on examination, her power, sensation, everything were intact. So this was her X-ray initial. First, we got an X-ray. This was her X-ray. This was an MRI. It showed a lesion in L2. It is not a spondylodiscitis. There is no much of a pus, but still some fluid collection surrounding the vertebral body. And this is the CT scan. So, Shailesh sir, would you like to tell something with the plan? How should we go ahead? Or
And sorry, I was just not. Just please
yeah,
ask.
I'll just show you again, sir. So it's a 14-year-old girl who had pain of low back for 2 months. The pain intensity at presentation was 8 out of 10 VAS, disturbing her activities of daily living, and constitutional symptoms started by the end of these 2 months. This is her X-ray. This is the MRI, which does not show any disc involvement, some amount of fluid collection, and the CT scan.
Is the biopsy was done?
No, sir. This is at presentation. These were the investigations we had.
Probably this is a central type 4, what is been described in Kumar's, and that can be a possibility for a young girl in India. There's a possibility that this can be TB. I will prefer to do a biopsy. And how bad is the deformity clinically?
Clinically, she had no deformity.
Probably, I think
There was no gibbous,
yeah,
or anything.
First thing first, I will do a biopsy.
Okay. Okay. So, Abhay sir. Hello. Abhay sir.
Or anyone.
Yeah, Suresh sir.
Samir, anyone? Mohit?
I think I agree with Hadgaonkar sir. I think I'll go for the biopsy first to know what the diagnosis is.
Okay, fine. But shall I continue, sir?
Yes, please go ahead.
Yeah. So we went on with the SIN score, and we thought that there is significant instability. It's a cord at risk, and we did a single position lateral robotic surgery, minimally invasive stabilization, and anterior L2 corpectomy and reconstruction with biopsy. So this was the planning. This was the placement of screws in single position lateral.
As the patient was in very bad pain, you can always consider a definitive treatment.
Yes, patient was she was not sleeping in the night for the last 10 days. So this was. this is the final picture. And then the biopsy came out to be TB, sensitive to rifampicin. So we started her on ATT, and then she gained like at least 10 kilos in a period of 1 year.
Perfect. You did a complete job and a complete treatment what she needed.
Yes.
Any questions from any other panel faculty to Dr. Vignesh? I think we have seen a very beautiful surgery where you've done a front and back in same sitting, and you did a complete corpectomy. The deformity and the tissue is taken out, and you stabilize. I think one of the very beautifully executed robotic spine surgery. Thank you, Vignesh, for sharing this with us. And thank you, Dr. Sajan. Also, we saw it in the picture,
Yes.
Dr.
Yes.
Hegde and your team. We move on to the next presentation with Dr. Piyush Chowdhury, the infectious disease specialist, where we need him every week nowadays because there are various different infections which we are seeing. I have seen around 16 different type of infections in my own practice, and Piyush is there to support us. Over to you, Dr. Piyush Chowdhury. Can you please share your screen?
Yes, sir. Yeah, is it visible, sir?
Yes, you can, yeah, enlarge it, yeah.
Yeah, so I think we already had a nice kind of cocktail of different kind of spine infections, and because we had a fairly detailed discussion of TB spine in the previous two sessions, I'll be doing three or four brief cases where I don't know why it is different. Yeah. So, the usual deception when it comes to spine infections is that whenever we see destructive lesion, the first thing which comes to our mind is TB. No doubt we are correct more often than not in India when it comes to TB, but then those few cases which may not be TB and maybe something entirely else could be the things which we would definitely want to pick up because TB as a reflex we would always keep in our mind as far as our Indian patients are concerned. So the first trap when it comes to non-TB things, I would say is a destructive, infective. Destructive is always equal to infective. Well, we would beg to differ. So this was a young medical student doing her internship, and she presented with a chronic back pain, typical that night pains, making her wake up middle of the night with pains, which we typically associate with either TB-related bone involvements or at times even malignancies. And there at her parent institute she was started on AKT based on her being a medical student and with this MRI. Now initially there was improvement in terms of her pain and all, but this was the further MRI which when she came to us, and there was increased destruction of the L3 body. So because initially there was no biopsy done, this time they thought of doing a biopsy which showed changes of fibrosis, chronic inflammation, and focal ill-defined granulomas. And in view of past treatment, they said above findings suggest post-treatment effect. So all were happy. The TB tests were negative, but AKT was continued. Several months later, her MRI showed further destruction of the body and her pain increased, and this time she underwent for an open biopsy. Now the first histopath showed florid clonic inflammation, no evidence of TB, no caseation, but then she was already on AKT for almost 6 months by now. Second opinion was taken, again dense acute and chronic inflammatory granulation. But when we did ISC, because all our TB test, including pyrosequencing, which was discussed in one of the previous talks, which is available at Hinduja Hospital, and now more and more centers are about to start it soon. Everything else, including the 16S, 18S, rRNA sequencing, everything was negative, and this bone was badly destructed, as we can see here. And to our surprise, after 6 months of AKT, believing that this was always TB, the immunohistochemistry showed non-Hodgkin's lymphoma. So essentially, the message that we take here is that not every destructive lesion is TB, even in India. So if the disease goes on worsening, then we should always question our diagnosis when the patient is on appropriate AKT and still the disease is worsening. And as we can see here with chemotherapy, she luckily improved quite well. I'll quickly move on to the next one. This I think was a very straightforward one. A typical thoracic spine involvement, even gibbous and deformity and everything. Again, TB was thought of, but like we have been discussing in all our cases today, this gentleman did undergo a biopsy first, followed by the surgery, and biopsy showed MRSA vertebral infection. Again, a fairly common thing when it comes to pyogenic to have MRSA infections causing large collections, extensive destruction, and even paradiscal involvement at times. Now, this is one important thing in the current scenario, that this was a man who had undergone a lumbar surgery. Yeah, so he had presented with history of L3, L4 infective spondylolisthesis post debridement and stabilization several months later with local swelling, pain, fever, chills, raised CRP, WBC and other inflammatory markers. Underwent debridement, implant removal and vac application. Now, by this time, because of his prior surgical history, he was already on meropenem and teicoplanin, as would be the empiric choices at most centers. And cultures at 48 hours showed no growth in the samples. But we did what we call as biofire joint infection panel. Now, this case I've taken mainly to highlight the importance of this panel when it comes to spine surgery, especially the post-operative infections, or where we have a very strong suspicion of pyogenic infection, and the patient typically in tertiary care, they come having received a lot of antibiotics at other centers, so we may have cultures negative at times. So here, as we can see, streptococcus species was detected. So when we pursued the culture for prolonged incubation, we did get Streptococcus mitis, which is a oral pathogen. Patients who are elderly, immunosuppressed, who have very bad dental caries. So this bug can cause spinal infection. In fact, recently there were some papers from some of the spine surgeons of Streptococcus mitis or oralis spondylodiscitis in native bones. But in our case, it was following a surgery and then SSI after a long time. Perhaps it was hematogenous spread in this patient who was elderly and immunocompromised. So the next two brief cases where we need to look beyond spine. So the first person was a person from Narayangao, which is a kind of a rural place near Pune, and he was a farmer by profession. And previously he had history of being treated for respiratory infection, then UTI, then multiple hospital admissions, newly detected diabetes, poorly controlled, and now he was referred to us for persistent fever, chills, weight loss of more than 10 kgs, and the PET scan which was done as part of fever workup at that center had shown lumbar spine involvement, first costochondral junction involvement, in addition to several other lesions which were there at different points of time in his history, from lung to requiring recurrent UTIs, requiring orchidectomy for testicular involvement and so on. And in this particular patient, again, all the bacterial and TB related tests were negative. But what we got positive was Brucella, IgM and IgG. Now here, more importantly, because the IgM was just borderline, we did Brucella cap test, which is a immune capture assay. This is again available at some of the centers. One center in Pune also does it, which was clearly positive. And in these cases, it is extremely important to get blood cultures and to inform the lab to keep it for prolonged incubation, because the blood did grow Brucella melitensis, which is associated with sheep. And in this some belt of this rural part around Pune, Narayangao, Junnar and all that place, many of these farmers have sheep rearing at their farms. So Brucella is exceedingly common in this part of the country, and I think Hadgaonkar sir would agree that I think Brucella must be the second common infection in spine that we see after TB in our practice, in spite of having most of our practice from urban setting. Yeah, on the outskirts of the city or in the semi-urban area, Brucella is fairly common. So we have to be quite open to this epidemiological possibility. Now, this was another case where it was quite straightforward, a pyogenic infection, as most would agree, a dialysis recipient, previous history of bloodstream infection, then spondylodiscitis. So mostly must have been a same organism is what all thought. And MRI did show infective changes. Biopsy was done, culture on biopsy, biofire, joint infection panel, gene expert, everything was negative. So here what was important is when we reviewed his past history of that bloodstream infection, which again is extremely important in addition to doing the correct samples in the current admission, the bloodstream infection was with this organism. We need not go into the details of what this organism is, but what it means is basically this is not even included in the biofire panel. So revisiting the past history of the patient and the previous cultures which patient might have had before he actually presented to us with spine infection can be of great help in such patients, especially these dialysis patients, uh, onco patients who have those chemopods, who may be susceptible to bloodstream infections. Going through their past records can many times lead us to the correct diagnosis. I think I'll not go into much detail of this because I'm sure at most of the tertiary care and teaching institutes nowadays this biofire joint infection panel is readily available. And although it is not a typical spine infection panel, there are now enough papers coming up in literature where this has been off-label used for spine infections when it is suspected to be pyogenic. But we should remember that it does not replace the traditional cultures, the TB testing, Brucella directed testing with serology and immune capture assays, histopathology, and above all the clinico-radiological judgment. This case I will not go into detail because TB we have already discussed. And this last case, after which I will stop for any questions. This was a gentleman who had undergone at another center a cement vertebroplasty for he had multiple comorbidities and osteoporotic fracture. And then after a few months, for a few weeks from there, he developed pain and fever and local swelling, underwent debridement in some center, saying all reports were negative. And they then removed the their x-ray showed this vertebroplasty location, and then eventually he was told to trace MGIT, which never happened. He underwent another surgery at different center with hemilaminectomy and decompression and fixation, where gram Zn bacterial culture gene expert all were negative, but histopath showed granulomatous inflammation with multinucleated giant cell. So any guesses from any of the panelists here?
Yes, Mohit. Suresh.
Atypical mycobacteria, sir.
Yeah, so this is extremely important that although TB remains the most common granulomatous infection in our country, this person was somebody who has gone a instrumentation at a peripheral center. I mean, with all due respect, we don't know what kind of infection control practices which could have been practiced there and what precautions were taken or not taken. And as thought of, it grew non-tuberculous mycobacteria, rapid growers called Mycobacterium abscessus. And we were in a bigger trouble because someone else at another center had already done a fixation there. And these bugs, as we all know, they just do not clear unless all the hardware is out, which is extremely difficult when it comes to such spine cases. I mean, for hands and legs, perhaps it would be much easier than spine. So just before ending, I'll just end with these two slides. That of course TB remains the commonest thing in our country, but I think if we focus on three things: what was the tempo of or the evolution of infection, whether it was acute or subacute versus indolent. Then secondly, what was the epidemiology? Like in our second case, the farmer, the exposure to sheep, animals, unpasteurized dairy products, all these things can be important. Any past procedures, this makes TB less common and something like a non-tuberculous mycobacterial or pyogenic infections much more common. And of course, in addition to what MRI tells us, which would be basically where is the involvement and whether there is instability, impending nerve compression and so on, we should always try to do microbiological and tissue diagnosis because MRI often doesn't tell us the organism which has caused this problem. So MRI basically will tell us the phenotype, history will tell us the probability of all the suspicions that we have in mind, and microbiology will ultimately lead to the actual etiology. So before we call any spine infection TB, I think these are the 5 questions we should all ask ourselves. One is whether it could be a mimic. Second, whether it could still be pyogenic based on the patient's, say, inflammatory markers, the course, prior comorbidities, and so on. Whether bloodstream infection was already there in the past, then that makes again pyogenic more likely. What is the epidemiology suggesting? and if I have tissue, have I used it properly? So like in the very first case, if we have taken a tissue, which is extremely difficult in most such cases, we should subject it to all necessary tests at once, because it may not always be possible to take tissue again and again when it comes to spine. Thank you.
Any questions to Dr. Piyush?
So I had one question. Actually, this is a case he had come to OPD. He was a 70-year-old who had undergone 2 epidurals for pain outside. And suddenly, last 10 days, he had severe back pain, and an MRI was done, and it showed discitis. The
Yeah.
problem was that we were not able to do the CT biopsy because the radiologist said he's on clopidogrel, so we had to delay it a little bit. But his counts were definitely high. So in such a situation, empirically, usually what antibiotics do you prefer to give? Urine culture was negative and blood culture was negative, so we were actually waiting for the CT biopsy report. So I just want to know, empirically in this, you
No,
don't
so
want to
CT
waste that.
biopsy was done afterwards. I mean, after
Yeah,
stopping
but that
procedure.
5-day lag, we just want to
Yeah.
know empirically, what would you prefer to give? How would you cover? Which antibiotics would you prefer to
No, so
cover the
most
patient
often
with?
than not, unless for major lapses, we will not have NTMs in such cases. It would be pyogenic usually.
Yes, sir.
So the bare minimum we would cover is the skin organisms which would be gram positive. So giving something like a ticoplanin, because all your this MR cons, MRSA and all are extremely common when the person has undergone a procedure. But in Indian context, gram negative organisms are also equally common in hospital acquired infections. So we would also like to cover with either meropenem or piperacillin tazobactam, although piperacillin tazobactam these days is not very sensitive in most of these cases. But that is only after we have taken the biopsy and we are awaiting the reports,
Right. So
not before
Tagocid
biopsy
is
process.
your go-to with
Yeah.
peptides.
Yeah.
Okay. Okay. And so actually, Dr. Tausif had a question for you. He is asking if there's any role of cardiac screening in systemic disease of infection. That's what he's, that should we
So,
screen when we are all the, cultures are negative, everything is negative.
so I mean, I suppose he's asking from endocarditis point of view.
Yes, sir. Yes, sir.
Yeah. So there, I think role can be there, but I think more important is to get multiple blood cultures. I mean, although when we are speaking of spine infections and the patient would be typically under a spine surgeon, but this is one place where if pyogenic is high on the cards in terms of our pre-test probability, then we should set multiple sets of blood culture, because many of these pyogenic are ultimately hematogenous, and if done before antibiotics, we can get cultures positive.
Okay, sir. Thank you, sir.
Thank you, Dr. Piyush. I think it
Thank
was
you.
a great presentation, and probably it will be useful for many of us. We move on to the next, again, interesting presentation by Dr. Suresh Pillai, and we have arranged Dr. Jaspal to play the presentation. Is Dr. Jaspal around?
My screen.
Yeah, please share the screen. Yeah, Dr. Pillai?
Yeah, I'm ready.
Yeah, we have one interesting case. After this is Dr. Muta, and then the review of literature.
Yeah.
Yeah, close to the later. Yeah. Yes.
Yeah.
Please start.
Good evening, all of you. So the next slide, please. Next slide. Next slide.
Yeah.
Yeah. So the one set is the patient was a 55-year-old female who underwent posterolateral fusion L3 to 5 for a spinal canal stenosis on 6th of June 26. Within a week, she developed fever, headache, and wound sockets. This is a classic triad of red flag triad of dural tear with a CSF leakage and secondary infection. However, because of her history of migraine, the consulting neurologist anchored heavily on this diagnosis. A brain MRI was ordered, but it was not looked at properly. The early small septic emboli lesions were missed, and the headache was treated as benign migraine flare-up. Due to this diagnostic failure, the intracranial pathology escalated. The patient developed severe extrapyramidal features, a mask-like face, frequent localized myoclonus, and full-blown seizures, forcing her transfer to our casualty department on 15th of June. Next one. Next slide, please. So play the video. Yeah. Open the wound. You can see the pouring CSF from the wound. and she had clonus and tremor-like features. So an imaging was not possible at that time. The patient was empirically put on, discussed with the neurologist as well, from our institution. And we have put her on meropenem and vancomycin, and anti-epileptics were added. And she became better. Next slide. Yeah. She was admitted, and after a few days, we did MRI, and the patient was extremely toxic, and she had active fluid soakage from the lumbar wound, severe local pain, neck stiffness, meningism, and prominent focal generalized myoclonus with tremors. First, we did an LS spine MRI, confirmed a large pseudomeningocele representing a persistent dural leak that was allowing CSF to escape and skin flora to ascend. Second, we performed a brain MRI under anesthesia on 18th of June. It showed a devastating consequence of delayed diagnosis: widespread septic cerebral emboli, active cerebritis, multiple microabscess, and surrounding hemorrhagic embolic infarcts across the frontal, parietal, and temporal lobes. EEG on 17th already confirmed its temporal spikes, indicating highly irritable infective cortex. Next one. Next slide, please. Yeah, you can see the MRI showing the pseudomeningocele. Next one. And lesions in the brain as well. Next one. So to guide treatment, we had to isolate the pathogen immediately. On 19th, we performed ultrasound-guided aspiration of CSF directly from the lumbar pseudomeningocele. The microbiological finding was highly sobering. CSF NGS immediately flagged E. coli, but the culture actually grew extremely drug-resistant Klebsiella XDR strain. This bacterium was resistant to all standard frontline antibiotics. It showed sensitivity to tigecycline and crucially a positive synergy for ceftazidime avibactam combined with aztreonam. Simultaneously, we ran a cardiac workup to rule out any infective endocarditis as a source of brain emboli, and the heart was normal, and confirming the spine was the sole source. We did an ophthalmology consultation and checked her eyes on 17th and found no papilledema initially. Next one. Yeah. So with the pathogen identified, the patient stabilized. We performed a definitive surgery. Next one. You can play the video.
Able to play it.
Okay. Show the picture then. So I found out the dural leak. It was repaired with the 6-Proline and PC glue. The instrumentation was intact. There was no loosening, and so I retained the implants there. On 27th, we switched the antibiotics from empirical drugs to targeted synergistic combination of IV aztreonam and avibactam 2.6 gram TDS. Postoperative care was aggressive. She was laid flat for 7 days, and the wound healed. And later, her suture was removed. And next slide. So the most important part of this case is while the spinal wound was completely healed and the CSF leak resolved, the patient continued to experience minor on and off headache with mild myoclonus. On July 13th, ophthalmology consultation was done, and they found out papilledema and some hemorrhagic dot and blot hemorrhages bilaterally, indicating the high intracranial pressure. Then on 18th, we did a MRI and MR venogram to rule out the cerebral venous thrombosis, which could be associated, and it showed new ependymal enhancement and ventriculitis. when we discuss with the infection disease specialist and the critical care people and neurologists, they told it has a very downhill prognosis, and whatever you, even with the sensitive antibiotics, she was getting worsened. So finally, as a last resort, I just started on put her on meropenem as well, which was a resistant drug. But luckily, she went on to improve. With the meropenem 1 gram IV TDS, her headache, her intense headache came down, and now day 63, now she is free of headache for the last 2 weeks, and she is walking around normally with all the wound healed. And we did a repeat scan. The previous one, it shows all resolution of the pseudomeningocele, the brain lesions, all were healed. Then I discussed with the microbiologist about the culture sensitivity. Then he told me that even with, if the inoculum is very massive, then the uh, antibiotic may appear resistant, even though it is sensitive. So this was, I just tried with the meropenem, and the patient was saved. So let us conclude with our clinical axioms. The surgeons, we must spread this message to our peers as well. First, never ever accept a diagnosis of migraine in a patient who has recently undergone spine surgery and presents with headache, fever, or wound sockets. It's a spinal leak and suspected meningitis until proven otherwise. Look at the MRI yourself. The neurologist missed the small abscess because they looked only at the report or the scanned images too quickly. Personal verification of radiology is a spine surgeon's duty. Second, if a patient has an active spinal leak, do not delay. The longer the dural tear is open, the higher the risk of ascending XDR infections. Take them back, repair the dura, and if the implants are solid, leave them alone. You can achieve complete cure without hardware removal. Third, when dealing with these highly resistant nosocomial bugs, we must leverage multidisciplinary teams. The combination of next generation sequencing for fast identification, targeted synergistic testing, and close cooperation between spine surgery, neuromedicine, infectious disease, and critical care and ophthalmology is what saved this patient's life. Thank you, and I am open to questions. Hello, am I audible? Did you all hear me? Hello?
Yes, you are audible, sir.
Any questions?
I think there are no
Shailesh?
questions. We can move on to next talk if no one has any questions.
No questions from the audience as well.
So I think we'll move on to the next talk by Dr. Mohit Mehta.
Good evening, all. Thank you for the opportunity, ASSI and Shailesh sir. This is a 54-year-old female. She had severe low back pain, left-sided.
Can you full screen your layout?
Can you see my screen?
We are able to see your screen, but it is not full screen. I think it is frozen.
Yeah, I can see my screen as full screen.
No, I think it is frozen.
Are the slides?
Okay, sir.
I'll share again.
Yeah, it is better you slide down, I think.
Now it's seen, Jaspal.
Yeah, we are able to see.
You can see the full picture, right?
No, we are not, just a no, we are not able to see full screen. I think it's better you keep it minimized and then scroll slide. Now we are able to see.
Right?
Yeah.
Sorry for the glitch. 54-year-old female, severe low back pain. She presented with left-sided partial foot drop. She was in bed, unable to walk. These are
Excuse me,
her
sir.
MRI pictures.
Your screen is still not visible.
Can you see now?
Yeah. Now I'm able to see.
Yeah. So she's 54-year-old female, severe low back pain, unable to move from bed, left-sided foot drop clinically. She had undergone a transforaminal endoscopy for probably biopsy. Able to So these are her MRI pictures. Endoscopic biopsy was done. It had no diagnosis revealed. Gene expert was negative. Histopath was probably not sent. No culture. And she has deficit non-walker, but she was started on empirical ATT, which didn't help the cause for her. She was still in pain, probably due to instability. So these were her pictures. Challenges were persistent infection, no sensitivity testing, no tissue diagnosis in the anchor points. So the plan was to give robust stability, debride the disc, get the adequate sample, do bone grafting and find the bug first. Are there MIS ways to solve the problem? So as her L was destroyed, I had to plan pelvis fixation. This is the MIS way to fix into pelvis. You want the track is lined on guide wires, and the intersection point is the incision. You take a 2 centimeter incision, so your finger can pass. You can only the skin incision is made. The entry point is slightly varied as compared to the traditional S2AI or the iliac bolt. It is 1 centimeter above and just beyond the SI joint. It is described as anatomical portal for iliac.
Is some issue there? Hello? Hello, Jaspal?
Hi, sir.
Is some issue there?
No, I think it has abruptly stopped. The presentation has abruptly stopped for Dr. Mohit Mehta.
Yeah.
Hello.
Yeah. Go on. Some issue in the network, I think. Yeah.
So this, can you see the screen, sir?
Yeah. We can see.
So this is the traditional entry point by osteotomizing the PSIS, and the anatomical entry is on the medial crest. It is 1 centimeter above and lateral to the traditional S2AI entry point, which is the lateral border of both the foramen, the midpoint there. So it's now been described in literature also. Problem is the length, screw length, which is still not easily available. So you have to have the teardrop view to pass the J needle in between both the cortices of ilium. You can put the guide wire This was my picture. As she had deficit also, then one side MIS decompression and bone grafting sampling was done. Other wires to put. Now I had to use an open screw for the ilium. So tapping was done the traditional MIS way with all the dilators. Then the MIS rod could easily be passed because the entry point was changed. The rod easily falls just above the tulip of the ilium screw. You just have to take a nick in the fascia and you can push the rod with a rod pusher. It is easily done. So this was the final incisions. The 4 for the screws, 1 for the T-leaf one, and the midline 2.5 centimeter for both the iliac screws.
Yeah, Mohit, I think your screen
She
is not
started
moving. Mohit, your screen is not moving. It is there itself. Can you just check if you can scroll it down? Some network
Sorry,
issue.
sir.
It's okay. You can just show the last picture, the image picture,
Yes,
X-ray. That's good enough. Yeah, that should be good enough. Yeah, that picture. Yeah, that's good enough.
this is the final picture.
I think it's not opening up in the.
6-month follow-up.
Just go back to what you showed, Mohit. This
Yes,
is
sir.
good enough. Yeah, we
You can
see.
see, sir.
Yeah, this is good. Yeah.
So the take home is if you can get the teardrop view, any disc which is like this at the alpha S1 level, you can easily tackle it MIS way. This is another case. I've done 6 of them. They all are doing well. The infection rate for traditional open iliac screw is around 10%. In this, the literature is yet to report an infection if iliac screws are put MIS way. So for my case, the take home was biopsy is must. If she would not have developed deficit, I would have definitely done a biopsy again. The need of surgery is in instability and deficit, and MIS options are always there. Thank you. Sorry for the glitch.
Thank you. Thank you, Mohit. It was a wonderful presentation. Very unique trick to deal with this challenging situation, and the way you done the MIS. I think it's a lot of learning for all of us. Any questions, or we move on to the next one? Yeah, you can stop sharing. Some technical lag is there.
We have stopped the sharing.
Okay. Is my screen is seen?
Yes, sir.
I will just quickly go through in a very, very short time. A 76-year-old man, back pain persistent, and he comes to us. His current labs were ESR was 38, CRP was 32. He was with couple of surgeries in the past. 14 years back, we had done his lumbar spine surgery. Then 5 years back, he did lumbar decompression elsewhere. Then 4 years back, he was treated for infection in D10 level with 6 8 months of EKT, and it was stopped. And now he came to us with 4 months of persistent pain, difficulty to sit, walk, and quite significant disability. You can see that there is something which we can see at thoracolumbar spine, and this was the pseudoarthrosis, which was troublemaker. We tried to see that whether there is any infective focus. We did a biopsy, but nothing actually came out. And in view of his persistent infection, we planned for stabilization and decompression with debridement of that particular area. And this is what we did. We could manage to get a good graft. We removed it. Maximum curettage was done, and we put a good amount of bone graft there. And this is what was, to our surprise, it was a pseudomonas. Uh, and again, the ID specialist treated him with meropenem, it was sensitive, and he is doing good. The labs are completely normal. It is around 3 to 4 months now. He is asymptomatic. He's significantly better in terms of his pain, which was 9 to 10 on 10. Again, these are the patients which we are seeing quite often nowadays. 56-year-old female. We have seen a lot of husband and wife coming with back pain, 6, 8 months, 1, 2 years of back pain treatment, very low grade pain, and persistent with no relief. With medications, and a lot of antibiotics are given to these patients, and this is what we can see. There is a disc height which is reduced at 543 to L23, and when we did the MR we can see something. And a lot of time radiology nowadays, a lot of reportings can be misleading also. They say early infection, inflammation, and schmalls, various things are said, but we need to do all the proper investigations. And this patient was with Brucella. CAPT test was positive. It was very, very strongly positive. We took again opinion of our ID specialist, and with antibiotics, strepto, doxy, and rifampicin. This is a 3 month and absolutely asymptomatic. A lot of patients, we have more than 20 patients of Brucella, and people with the cattle and contact of these kind of animals at home have a very, very high chance of having Brucella. We are seeing quite a large numbers in Western Maharashtra region. Thank you. Thank you for patient hearing. Because I wanted to cover up different type of pyogenic infections, and we have seen a battery of different investigations. So I think in want of time, we move on to the last presentation by Dr. Nrupam Mehta, and she'll be talking about the review of literature, and we complete the webinar today. Over to you, Dr. Nrupam.
Uh,
Yeah. You want me to stop?
sorry, sir.
Yeah.
So I'll just share my screen.
Yes, please.
So I'm just going through a quick review of literature for spinal infections, basically what we've heard throughout. What does the literature actually tell us across the spectrum? Pyogenic, tubercular, fungal, parasitic, is it the same disease, different rules? Are we diagnosing fast enough? And when does the surgery actually outrun antibiotics and when doesn't it? What happens when the infection follows our own instruments and what's still unanswered? So basically, it's just going over decades of spinal infection research. 1917, it was actually introduced that pyogenic vertebral osteomyelitis is a distinct entity. It has hematogenous, contiguous, and vascular classification established. Then in the 2020, spinal TB literature matured alongside pyogenic disease. So we were even thinking about TB and making our algorithms as to what has to be done. My mentor, Dr. Nene, has also reshaped ATT duration from 12 months to 6 months during the same period. And hydatid and fungal is not something that we see even now. So they are very isolated case reports and very, scarce literature on it. So, what are the landmark publications? Kolosky, Waldoville, Bernard, and Nene sir. All of these guys basically spoke about pyogenic vertebral osteomyelitis. What is the type of spread? Is 6 weeks of antibiotics enough, and or do we need to go up to 12 weeks of IV antibiotics? And 6 months of AKT usually for a non-resistant TB is enough compared to a 12 months final TB. So, treatment. So, how common is pyogenic? I've just divided into pyogenic, TB, and post-op. So, it is pyogenic spondylitis has been increasing because of aging population, IV drug use, hemodialysis. So, zero point 0.2 to 10 per 1 lakh a year, rising incidence, and up to 20% have actually reported mortality in pyogenic spondylitis. This is something we should be aware of. And S. aureus, Staph aureus, is the most commonly detected organism on CT biopsies in the lumbar spine. So we are still escaping diagnosis because everyone is still not aware that non-specific back pain can still mean infection, and we tend to get down to the radiological evaluation much later. And that's why we are always delaying treatment. Patient comes up with neurology, and everything is just delayed. So fungal spine, there are only hardly 118, which more were aspergillus. then followed by Candida, and usually it is surgery plus antifungals that we have already heard by the previous speakers. So hydatid is something that we don't commonly see. Less than 2% have hydatid cyst, and recurrence rate is definitely a problem. We've already heard from Bharat sir that how we can do a good dissection, prevent any spillage. That is the only way of controlling our recurrence rate. The antibiotic duration debate again, 6 weeks, 12 weeks, that keeps going on. Brucellosis is something that I've read about is should be around 12 weeks, and post-surgical duration still isn't settled by any RCT. Now, what is our main algorithm? Clinically suspected, do bloods, do an MRI with contrast, do a CT guided biopsy, and repeat the biopsy even if your first biopsy is negative. And usually, just from the review of literature, pyogenic people are preferring vancomycin, MRSA, vanco, works best. Gram-negative cephalosporins with fluoroquinolones, and TB is a standard HRZE. Fungal albendazole does wonders, and as we have learned, it should be taken for a lifetime. So conservative versus early surgery, 8% versus 13% was the mortality in early surgery versus conservative. And if you went in earlier, they say this, hospital stay was significantly reduced. In TB, India is obviously carrying the highest burden. And there was a first systematic review of drug-resistant skeletal TB that was just published in 2025. And out of drug-resistant, 1242 were actually spinal TB. And post-op infections, what do you do when the infection follows our own surgery? 2 to 4% incidence after instrumented spine surgery across recent. So instrumentation is definitely higher. It is the third most common complication seen in surgery. And look out for very comorbid patients. The incidence of infection is increasing in these people. And post endoscopy infection rate, we don't have enough data. But as in when more years pass, we are hoping we can actually get real good numbers. And what are we still not sure that should we go in quickly? Is 6 weeks enough for every organism, every patient, or should we prolong it, clinically assess, do bloods? And do we need a multinational RCT before practice really shifts? What is our take-home message? The evidence leans forward towards earlier, more decisive intervention than most practice. Diagnosis is more important than the treatment because of the delayed diagnosis in very atypical presentations. And drug-resistant TB, higher still run almost entirely. Thank you.
Thank you, Nrupam. I think it was very, very nicely covered up, and what's currently going on from the way, almost in the 18th and 19th century you covered up. So we have covered up maximum difficult and challenging scenarios, and also extensively TB investigations, treatment, XDR, MDR, and pyogenic. I think we try to cover up a lot of things, including hydatid cyst and fungal and post-operative infections with different techniques, and also we are not left the robotic. So thank you once again, all the extremely beautiful presentation by all the faculty. My coordinators, Dr. Nrupam Mehta and Dr. Jaspal Pardeshi, the team ASSI, Dr. S.K. Srivastava sir, Dr. Appaji Krishnan, and Dr. Ajoy Shetty for their great support, and my co-convener, Dr. Abhay Nene, for the wonderful cover-up. And all the audience, we look forward seeing you on the second Tuesday next month. Thank you for a great support once again. And at the same time, I would like to thank the team OrthoTV and team ASSI TV for this wonderful academic initiative. Thank you. Thank you once again. Good night. Good day.
Thank you, sir.
Thank you.